My name is Lenny Jason. I am a professor of psychology at DePaul University in Chicago. I'm also the director of the Center for Community Research. I've been at DePaul University for the past 39 years. I initially got involved in ME research in the early 1990s. At that time, people were talking about this disease as the yuppie flu. What I found was that the CDC had done some prevalence research called the 4-City study, and they had estimated that fewer than 20,000 people had this illness. I was very skeptical of that research, and as a research psychologist, when I looked at their methodology, it was significantly flawed. For example, they had people refer folks into their study who had been, in a sense, identified by doctors as having ME. And yet, as we know, lots of physicians don't even think this illness exists. So how could they refer people into their catchment prevalence study? So basically, looking at that research, realizing the CDC at that time was getting several thousand phone calls every month about severe fatigue and possibly ME, I was skeptical, and I decided that I would try to work with some colleagues working on a prevalence epidemiology study of adults. After looking at the research literature, we found that basically there were better ways of estimating prevalence than through physician ascertainment methods. So what we did was we wrote an NIH grant, myself, Judy Richmond, and several other colleagues. And we were able to get funding to actually sample 26,000 people and tried to find out in that large sample, a community-based sample, how many people might have ME. And what we found was that the rates were much higher than what the CDC had estimated. So by the mid to late 1990s, we were able to make projections that approximately 1 million people had this illness. So that was one of the first large studies that our group did, but it took us 10 years to work on that basic epidemiology, from writing grants to getting it funded, to doing the research, to publishing it. So it is a long time commitment to do this type of research. I think one of the important things that we learned was that not only did more than 1 million people have this illness rather than 20,000, which was estimated, so it wasn't really a rare disorder, but in fact the yuppie flu was really a myth. The people we found that had this illness did not tend to be yuppies. In fact, we found people who had lower incomes had more likely to have this illness. So folks who were minorities, people of color, were more likely to have this illness. So that was an important finding, both the prevalence as well as the numbers. And that led us ultimately to make statements about this illness that really we needed to have more public resources devoted to it, in part because it wasn't a rare disorder just affecting a bunch of middle-class individuals who were possibly malingering or doing something else. This was a serious illness affecting a lot of people, many of them who didn't have resources and had other disadvantages besides the illness. Well, in terms of our current work that we're doing, certainly we thought that epidemiology was important to find out the prevalence rates for adults. We're now, in a sense, trying to do some community-based prevalence studies with young people, pediatric ME, and that's going to be the work we're going to be doing for the next 5 years. We're also going to be doing research on individuals who have mono, college students, and testing them when they're healthy, seeing what happens when they develop mono, and trying to follow them as to which ones recover and which ones don't. So I'll be doing work with Ben Katz at Children's Hospital in Chicago on those 2 very large projects over the next 5 years. The current research that we're doing is really wanting to kind of look at all the different parameters in terms of what are risk factors for those who end up getting ill versus those who don't, and particularly looking at them before they get ill. That's a very important factor. We have some research that we're just publishing that, for example, looked at mono in youth, and we basically have found that there was no psychological factors that were predictors as to which ones would get more severe illness and ME in the future. What we found was the severity of the illness that they got was really the only thing that was a significant predictor. So that's an important factor, suggesting that there might be more biological factors that involve both the initiation of this illness as well as its maintenance.
Heeft u een vraag naar aanleiding van deze video? Reageer op YouTube of tweet naar @ME CVS Vereniging of mail naar wvp@me-cvsvereniging.nl. Uw vragen worden zoveel mogelijk behandeld in de chatsessies.
You know, people started out calling this illness ME, and that was the British many years ago. And there's been a regression back to CFS in 1988 with people from the CDC in the US. I think there's been a movement to change that, and actually some people are calling it ME-CFS as a transition term, but I ultimately think this illness would be called ME, for myalgic encephalomyelitis. I think that's the legitimate name for this illness. In a sense, it got hijacked 30 years ago, and it needs to revert back to that original name. The name CFS is a terrible term that was come up with by the CDC many years ago in 1988. You know, if you think about someone who was coughing and you said that that was chronic cough syndrome, people would say, who cares? Everybody coughs. It just isn't a big thing. However, if we basically called it bronchitis or emphysema, people would say, gee, that really sounds like it's a significant issue. So the name counts, and you can't have a name for an illness that trivializes a condition. And chronic fatigue syndrome is one of those names that ultimately has to change. Our group actually did some research where we looked at attributions, and we put the name ME, and we gave a case description, and then we gave the name CFS, and then we gave the term Florence Nightingale disease. And we had the same case study, and we found that names do make attributions, and they do significantly differ how one thinks about those cases. And we actually did this research with medical interns as well as psychology undergraduates, and we found attributions do get changed based on the terms that are used to describe cases. The CDC criteria is often thought of as the Fukuda 1994 criteria. This was put together by a consensus of people, and I think consensus-based case definitions have problems. In specific, by having 4 symptoms required out of 8 possible ones, you can miss some of the cardinal symptoms of this illness. So for example, the 3 cardinal symptoms are post-exertional malaise, memory and concentration problems, and unrefreshing sleep. Well, if you can believe it, a person could have 4 other symptoms and not have these 3 cardinal symptoms and still get the term CFS. That's a major problem with an illness category when the cardinal features of the illness are not required to be diagnosed. Our group actually looks at several criteria and tries to basically have people fill out a questionnaire. And then we actually look at how a person meets the criteria for the 1994 Fukuda criteria, how they meet the criteria for the ME ICC, the new 2011 criteria, as well as the Canadian ME CFS criteria. So we try to compare and contrast those three. But I must say, there's limitations with all three, and that really consensus-based efforts are probably not the best way for us to come up with the best ways of characterizing this illness. The IACFS-ME put out a primer that basically used the Canadian consensus criteria of 2003. And we felt that there had been a good amount of research that at least had suggested that this particular case definition selected a smaller group of patients that had more functional impairment. So we decided to really focus our primer around a case definition that had been around for 10 years, that most importantly specified core cardinal symptoms: post-exertional malaise, memory concentration problems, as well as sleep difficulties. So that's why we decided to kind of write a primer and focus it around something, a case definition that we thought was an improvement of the Fukuda 1994 criteria. In fact, there was another case definition, ME ICC, that did come out in 2011 and 2012. But there hasn't been as much research done on that particular case definition. So we decided to use the one that had a little bit more been used by kind of research community.
Heeft u een vraag naar aanleiding van deze video? Reageer op YouTube of tweet naar @ME CVS Vereniging of mail naar wvp@me-cvsvereniging.nl. Uw vragen worden zoveel mogelijk behandeld in de chatsessies.
There's certainly lots of opinions about the cause of ME. There are individuals who certainly have a viral kind of beginning, sometimes mono. There's other people that have some type of accident that begins their onset into this illness. There's other people who have some type of environmental toxin or exposure, molds. So there actually are quite a few different types of things that seem to precipitate this illness. It's very possible that these individuals might have some genetic predisposition to this particular ME illness, just as other types of chronic illnesses have been found to have some genetic predisposition. But I would say that, at least at this point, there sounds like there are a number of triggers that could be the precipitants of individuals manifesting ME. There's terrible stigma associated with people who have ME. And a lot of people wonder, why is this the case? Our group at DePaul University has actually put together a scale that measures stigma so that we could get some clues as to what's going on. Certainly we have a society that basically values energy and stamina and endurance more than anything else. It's probably more important than even money, if you can believe it. And if you don't have those qualities of energy, you basically are a person who's probably more discriminated than any racial or any other type group in our country. Because energy is what makes the American dream. People who have fatigue basically are seen as being somehow deficient. And the reason is this: everybody feels fatigue at some point. Sometimes it's through a marathon race, but sometimes it's through having a couple jobs. Ordinary fatigue that most people experience is something that, probably goes away when they go on a vacation or when they're not stressed out for so many responsibilities. So most people think of fatigue in completely different ways than patients who have ME. So when a patient with ME kind of says that they basically don't have energy or don't have endurance or don't have stamina, individuals say, well, gee, I have all this stuff I have to do and I keep doing it. Why can't you? And worse than that, you don't look like you're sick. The combination of those different characterizations leads to incredible societal negative attributions toward patients that probably is almost like the 21st century of lepers, what it might have been like 200 years for people with that other disease. I think that it's important to diagnose ME not just by exclusions, but also by inclusions. Basically, we need to understand a person has core symptoms of this illness, like, for example, post-exertional malaise. That has to be there for this illness to exist. And yet some of our questionnaires basically sort of say, do you have sort of 24-hour sort of difficulties after you've exercised with some types of symptoms, including fatigue? Those questionnaires are problematic, and I'll tell you why. Because a lot of people don't push themselves because they're so sick. So they don't have to experience post-exertional malaise because they've learned in some ways to kind of really hold off and be a little bit of an energy bubble so that they're like that envelope that we'll talk about at another time. So in a sense, it's possible that some individuals, yes, they would experience post-exertional malaise if they were basically pushed, if they had to do exercise, if they had to do the daily tasks that most people do. But since they're not doing that, some of them don't even experience it. So if you ask the question, do you experience it? They'll say no. But the reality is they do have it if they have to do daily activities. So all I'm saying is that we have to be so careful that we phrase the questions in the right way to tackle these types of complex symptoms. And if you put a person on an exercise bicycle and really do a challenge, then you will find post-exertional malaise, particularly not after 1 day, but after 2 days. Because after 1 day, they're able to kind of push themselves enough to look good and have some of these oxygen exchanges. But it's the second day when you do the testing that you see the post-exertional malaise. So again, both with exercise challenges as well as self-report questionnaires, one has to be so careful about how one asks the questions so that we identify people who really have the core symptoms. And clearly, you don't want to bring people into your studies or into your practice who have another illness. So if they have MS, if they have cancer fatigue, if they have other types of fatiguing illnesses that are due to medications, you want to exclude them. If they have a psychiatric reason for their fatigue, like major depressive disorder with melancholic features, you want to basically exclude them as well. So you want to basically find people with ME, solely ME, and not something else. To get a diagnosis of ME, I think you have to have 3 cardinal symptoms: post-exertional malaise, neurocognitive problems like memory and concentration difficulties, unrefreshing sleep. Those symptoms, I think, need to be there. Not saying that there aren't other symptoms that could be there as well, some of the immune, neuroendocrine, and autonomic, but I would say the 3 that I first mentioned are critical. Over the last 15 years, our group at DePaul University has been working on developing ways of using self-report questionnaires to assess patients' symptoms. And our most recent effort is called the DePaul Symptom Questionnaire. We've actually put that on an electronic system called REDCap that now is available to anybody in the world that they can download. And this is basically a 54-item questionnaire that measures, we think, some of the current symptoms of many patients that have these types of illnesses. We have each symptoms rated for frequency and severity on a 5-point scale, and we've been doing some basic research on this questionnaire, making sure it has some good reliability and also validity. So we feel pretty comfortable that this scale could be used by people both in clinics as well as in research settings. And we have some investigators from different parts of the world that are currently using our scale. This is a questionnaire, the DePaul Symptom Questionnaire, that could be used really by anybody. It could be given to patients at a clinic. It could be given to researchers, to their subjects, participants in studies, or patients could fill it out. The thing that we like about the questionnaire is that we have built an algorithm, which is kind of a pattern of looking at the responses, so that after a person actually takes the particular questionnaire, we can score which case definitions they meet. So that gives us ability to use the questionnaire to focus on people in terms of how many of the critical case definitions they might have the symptoms for.
Heeft u een vraag naar aanleiding van deze video? Reageer op YouTube of tweet naar @ME CVS Vereniging of mail naar wvp@me-cvsvereniging.nl. Uw vragen worden zoveel mogelijk behandeld in de chatsessies.
Our group has been spending quite a few years trying to look at differences between major depressive disorder and ME. To put it real briefly, if you had a person with a major depressive disorder and said, tomorrow, if you were well, what would you do? The person with major depressive disorder would say, I don't know. If you ask the same question to a person who suffers from ME, they'd start compiling a list of things that they've wanted to do but haven't been able to because they've been sick. So there's an issue of really self-reproach. People with ME don't have kind of negative personal feelings about themselves. People with major depressive disorder do have that type of negative feelings about themselves. So self-reproach, kind of expectations for the future, and also exercise. People with major depressive disorder often feel better with exercising. And we know that with people with ME, exercise often induces post-exertional malaise. So there are clear differences between these two illnesses, and they have to be differentiated. There are a number of studies that have actually found physical differences as well, biological differences between people with major depressive disorders and ME. So for example, cortisol levels. Generally, they tend to be kind of lower in people with ME and higher with people with major depressive disorder. You know, if you ask the right questions, even with self-report questionnaires, one of our doctoral students was able to do 100% discrimination between two groups if you get it right. So that's why questionnaire development is so important, because if you ask the right questions, you can really discriminate people from these different illnesses, which is critically important for the research that we and others do. The best research really looks at things from a multi-dimensional perspective, using multiple disciplines. So for example, you want self-report questionnaires to be brief, so that you can find out what the basic symptoms are the person has. But then you want to follow it up with the physical examination, so that you can rule out other illnesses. If a person has lupus or MS, you want to rule them out. But you also want to have challenges. So for example, putting a person on an exercise challenge with a max or submax test, and that would basically find out some of the genetic markers that might differentiate patients from people who aren't patients. So in a sense, you really want is the best sources of data, so that we can really do comprehensive evaluations of self-report and medical domains, so that we can better characterize this illness. And if you miss one of these domains, you miss an important area of functioning to really help us understand these people. Besides major depressive disorder, which can be confused, and I think often is confused with ME, there are other types of psychiatric illnesses that can be confused with ME. So for example, somatization disorder is something that has been confused with people who have ME. There's also anxiety disorders that have been confused with people with ME. So yes, I guess what I'm suggesting is just as you go to a physician to get a medical examination, we really need to have, in a sense, structured psychiatric interviews to sort of make sure a person has particular disorders or doesn't have disorders. Because what you want to do is differentiate those people. And physicians, unfortunately, have not been trained to basically do a psychiatric evaluation. So often they don't know if a person has a major depressive disorder or somatization disorder. So you really want to have a comprehensive psychiatric as well as comprehensive medical examination before you determine whether a person has ME, because you want to exclude other causes of the person's illness. Every chronic illness has higher rates of people who have depression. So there's no reason that people with ME won't have some depression as well. Not all patients with ME, but some patients will. I mean, just think about it. If you have an illness that a lot of people don't understand, a lot of people don't believe, it's very debilitating, and you basically are often questioned about it, those are all reasons to feel discouraged. So in a sense, you might have, in a sense, kind of discouragement and a sense of, almost like hopelessness at times. That does occur. And I think we have to understand that that's the same thing that occurs with any types of chronic illness. The depression that occurs with any chronic illness starts with basically the people around that individual legitimizing what they're experiencing. Basically, the support systems around a person have to be examined. And if you have individuals, whether they're parents who don't believe a child is ill, or workers who don't believe the individual is ill, and if you have discouragement and skepticism, that's going to be a deadly type of influence that has to be removed if you're going to begin to treat an individual's sense of hopelessness or despair for being victimized with an illness that's so poorly understood by society. When a person has ME, I think it's important to treat all the symptoms that an individual has. So for example, if they're dealing with pain, there might be some types of medications that are used. If a person's dealing with any other types of symptoms, there's all types of medications that should be considered. In a sense, what the patient needs to have is the best team possible that works on the different issues. It might be nutritionist. It might be someone who deals with physical therapy. It might be different issues that the person needs help with, and we should basically have patients empowered to basically put together a treatment team to kind of meet their needs, which are often diverse. And that's the key to success, using both pharmacological and even non-pharmacological interventions to basically come up with a treatment program that basically meets each individual's needs. We don't have a lot of research yet in terms of comparing ME with lots of other conditions. I think we need that type of research because that will help us understand some of the similarities and dissimilarities. An example, in terms of MS, one of my colleagues, Matthew Sorensen, and I are just finishing a paper that's looking at brain proteins in MS. And we basically have found, for example, that individuals with ME tend to have the same level of low brain proteins, called BDNF, as people with MS. And that's one of the primary biological markers of MS. And what does BDNF brain protein make? The myelin sheath that allows the electrical impulses to go through the brain. So, and again, it's possible that MS and ME has some similarities that we really don't know that much about yet. But I think in the future we will do more comparative biological research to help us understand this.
Heeft u een vraag naar aanleiding van deze video? Reageer op YouTube of tweet naar @ME CVS Vereniging of mail naar wvp@me-cvsvereniging.nl. Uw vragen worden zoveel mogelijk behandeld in de chatsessies.
People who are psychologists, mental health professionals, have an important role to play in the treatment of any patient with chronic illnesses, ME included. What we need to do as mental health professionals is first validate the patient's experience. We have to listen and become an ally of that individual and basically really try to understand what they've gone through to build an empathetic bond. That's so important because particularly patients with ME have been so victimized by often the medical community and others that that particular relationship is critical to basically let that person know that we believe in them and we basically care about them. I think without that basic trust, you'll make very little difference and you'll basically, the mental health professional will actually be harmful to the patient without building that trustful relationship. Patients with ME need to have the best team possible, involving multidisciplines to basically have a good chance of getting quality care. But you can't just send a person with ME to a psychiatrist or a psychologist. The reason being because they probably need many other services that will help them deal with the many different symptoms of this illness. Just think about it. If a person with cancer came to a medical doctor and the doctor said, go see a psychiatrist or a psychologist, that's all you need, the patient with cancer would be terribly upset. And that's exactly what's happened with patients with ME throughout the world. There are many different types of treatments for ME, and I'm going to really talk a little bit more about what I think of as kind of in the lifestyle area, and the reason is because I'm a psychologist, but in the medical area there's also many good treatments for things like pain and sleep difficulties. But in terms of lifestyle issues, often patients feel like they have an energy of maybe 10 or 20% that they had formerly in their life. So their battery, their storage of kind of that electrical life force has been reduced, and yet their obligations are often to be doing twice as much work as they have the energy to do. And that's a problem. So in terms of lifestyle management, how do we get patients so that they're not doing too much, so that they're basically exhausting themselves and possibly entering into post-exertional malaise? So I think in a sense, learning how to stay within the energy envelope, what we call it, I think is critical to allowing that battery not to get further depressed and depreciated. That's, I think, what we need to do. And a lot of patients are kind of what's like a yo-yo. So what happens is they sort of are really sick, they don't do much, and they're really careful, and then they feel a little bit better, and then they do too much, and then they have a crash. That's a yo-yo effect. And I think everything possible to have that not occur is really critical in lifestyle management for patients with ME. You know, cognitive behavior therapy is something that's used with all types of medical illnesses with some very positive results. Why is it so controversial with patients with ME? Well, the reason is because often that's all they're provided. So, for example, a person who had epilepsy and needed medications, if they were basically said, well, just use cognitive behavior therapy, the patient with epilepsy would be furious. But that's what's happening with ME patients. They're basically having needs that are far beyond just psychiatric issues. They have somatic problems They've got physical dysfunctions. They've got irregularities that are biological. They need the best of medical care and treatment, and yet they're being siphoned to basically a very narrow type of perspective. That's why they're upset, because they're not being given what's appropriate medical care. They're being given inappropriate medical care that basically isn't meeting their needs. A number of people have been talking about pacing, some developments Ellen Goudsmit in Great Britain has written about. We in the United States have used something called the energy envelope. I think there's a lot more commonalities than differences between these approaches. Basically what they both are suggesting is that we need to help patients learn to kind of manage their available energy in a very sensitized, tailored, contextualized way. So for example, if a person has a battery that's maybe 20 or 30, and basically they once had a battery that was 100%, and now it's just a fraction of that. How do you basically do all the tasks of life on such a small amount of energy, available energy? So what we try to say is pacing, or basically staying with the energy envelope, is trying to sort of stay within that available energy and not exceeding it, not pushing oneself. Because if one does that, ultimately, I think one experiences more crashes, more post-exertional malaise, which I think ultimately does more oxidative stress to the brain, and I think will have some very negative consequences for the patient. So yes, pacing, energy envelope, those are the, I think, appropriate types of lifestyle changes that can make improvements, not cures, but improvements to many patients.
Heeft u een vraag naar aanleiding van deze video? Reageer op YouTube of tweet naar @ME Vereniging of mail naar wvp@me-cvsvereniging.nl. Uw vragen worden zoveel mogelijk behandeld in de chatsessies.
I think that there is evidence that the nervous system is aberrant in patients with this illness. And certainly some of the work of Alan Light and Kathy Light at University of Utah has suggested that when one puts individuals on some type of exercise submaximal challenge, one does see some of these types of genetic markers. So yes, I do think that there are kind of nervous system kind of domains that patients can have significant problems in. And I think that they directly are implicated in this particular illness. I think that for most patients, what we see is kind of a sympathetic dominance over the parasympathetic system. In a sense, their body is kind of, in a sense, tuned up. We often kind of see the symptom of called wired. And that's actually a very common description of patients. They're exhausted, but they're still wired. So in a sense, their system is upregulated. And I think everything that we can do to help patients down-regulate that system is actually healthy. And it's very interesting that lots of the pharmacological types of things that people sometimes try, including Klonopin and other things like that, seem to begin to help down-regulate that system. So yes, I do think that there is an upregulated system in many patients. Many patients with ME often have kind of a supply of blood that is just kind of lower than healthy normals. And what happens when they do a challenge to their body, which is called orthostatic stress, when they stand up, they often don't have enough blood to get to their brain. And individuals sometimes feel faint and they don't feel well. So that's because, in a sense, they're not getting enough blood from their bodies up to their brain when they stand up. So yes, there does seem to be some major circulatory issues among patients, and orthostatic intolerance is one manifestation of that. Post-exertional malaise can be measured by asking the right questions on self-report questionnaires, and also by using exercise challenges, whether they're by having people exercise on bicycles for 10 or 11 minutes, or even up to 20 minutes in a sub-maximal challenge. So yes, I think it's important to look at both what people say as well as what people do in the laboratory, and to bring the best of those two together to understand this complex symptom called post-exertional malaise. Many patients begin to become symptomatic after some type of viral infection. So it does seem, certainly in terms of sometimes in some samples up to 70% of people report having some type of viral infection. Ultimately, the best way we're going to understand the role of these types of infections is longitudinal prospective studies. An example is one that we're currently involved in Chicago with Ben Katz, who's at Children's and Northwestern. And we're going to be following thousands of college students who are healthy over time to see which ones develop mono and which ones recover and don't recover. And that's really the best way of us being able to identify whether a particular virus or any other types of things might be both involved in etiology as well as maintenance of an illness. Involving markers for ME, yeah, I think that we could say that we're beginning to identify some of them. And in the future, I think there will be many others. Certainly, cortisol difficulties. It seems like the people who have a lessened increase in cortisol in the morning might be a very good marker. Natural killer cell activity has been talked about in a number of review articles, as well as, there might be subgroups of individuals that have other types of markers. And I think that the future will hopefully be able to discover many more of these and be able to get them across laboratories. But again, if you're going to find markers, it's only going to be if you have the same types of patients in different settings. And that's why the case definition is so important. We have to identify the same people in different places if we're ever going to basically find consistent biological markers. The reason that's so important is if you don't find consistent biological markers, it's very easy for people to assume it's a psychiatric illness as opposed to a biological one.
Heeft u een vraag naar aanleiding van deze video? Reageer op YouTube of tweet naar @ME Vereniging of mail naar wvp@me-cvsvereniging.nl. Uw vragen worden zoveel mogelijk behandeld in de chatsessies.
Some people have asked whether ME is different in different parts of the world. Certainly there was initial myth that ME was more prevalent among yuppies, among people who are white and who are higher income. That myth is not true. So we actually know that ME tends to be more common among individuals who are lower income. So that is a big important thing. We also have found in the United States that ME tends to occur more often in minorities, of people of color. So yes, we've also done a community-based study in Nigeria, and we've actually found rates of ME to be higher than in the United States. So we think ME occurs in many different places around the world. In terms of which particular groups have higher rates than others, we're not sure, but certainly in the United States we found some differences and certainly people of lower socioeconomic status are more likely to have this illness. Whether ME is race-related is something that we really don't understand well. Some of the symptoms of ME, for example, orthostatic intolerance, do seem to be different in African Americans versus Caucasians. But in terms of us being able to definitively understand what are some of the factors, it's unclear. We did find, for example, Latinos in the United States had the highest rates of ME than any other group, and particularly among women Latinos versus men Latinos. So that was kind of interesting. We also found that Latinos who had been more acculturated, who had been more into American society, had differential rates than those who had not been acculturated. We do think that genetics probably makes certain people predisposed toward having a lot of chronic illnesses, and ME is probably a good example of that. We still have a lot more research to be done on that, but I think eventually we will be able to conclude that. That's my guess. In terms of whether ME is somehow higher in particular groups versus other groups, I think that that's something that future research will be able to better understand. I think at the present time, we still are trying to understand some of the risk factors for this illness. So basically, the best research that's going to help us understand some of these genetic markers is to actually look at genetics in healthy people and look over time to kind of see which ones develop ME and which ones don't, and then look at some of the risk factors, both environmental as well as biological. That's really the way we're going to disentangle kind of the genes versus environment and see the roles of these different things. There have only been a few long-term studies involving individuals with ME. It does seem like individuals who have longer illness tend to have more cognitive difficulties and more symptoms. I think that we actually have a paper that we're working on now that's trying to look at people who've had this illness for a longer period of time. There really aren't a lot of studies that have been published in this area, but it does look like length does increase some severity issues. Patients with ME have functional impairments as severe as any of the major illnesses, including cancer, and on in terms of different very significant chronic illnesses. So these are very sick patients, patients who really need the best of medical care, and patients who are often provided the worst. So we see some of the worst functional areas that people have is just physical capacity to do things. Endurance, stamina, that's probably the area where people have the greatest limitations. Sometimes cognitive confusion, where a person basically can't remember things or can't remember why they're doing something. And that often creates it very difficult for a person to be in a work setting. So yes, the physical impairments of being able to kind of do things consistently over time, and then the next day continue to do that. You see lots of impairments. Particularly for these post-exertional type testing, and cognitive challenges too, seem to really make it very difficult to think and remember things and to focus on things. So yes, there are neurocognitive and post-exertional functional impairments that we see in patients. Economic analyses have been sometimes done, and in America, our group has estimated that the cost might be up to $20 billion a year for the types of problems that patients have with ME. But the real cost is to the patient who basically is in a system that they have one of the most severe illnesses that we know of and are actually provided the least comprehensive treatment. So here's individuals who have one of the most difficult problems we can think of, and they're questioned about the validity of whether they really have an illness. Can you think of anything worse at a personal cost of being so sick and having people question whether you really are ill or not? Funding by the government has been very low levels. And what's needed is really kind of places that you can go to get diagnosed and treated. And these in the United States generally don't exist. So if you have cancer or if you have MS, you can go to specialty clinics and you can get the best diagnosis and the best treatment. But for example, I live in Chicago, and there really aren't physicians who are specialists who treat patients with ME. And that's a problem. So we need to have the types of healthcare that involve services that are available to patients. And right now they don't have the services, nor do they have the research dollar investment to provide the types of data that we need to find out what treatments, what pharmacological treatments are most effective with patients. So yes, in both the research arena and the service delivery arena, we're basically provided very low amount of resources given the severity of this problem that affects our populations. In terms of what can be done for patients with ME, I actually spent the last year writing a book called Principles of Social Change that Oxford University Press has published. And in that book, I really try to indicate, what other social change movements have done to bring about change, including the civil rights movement and other types of groups like the women's movement. And ultimately, it's endurance, it's staying committed to something over long periods of time. It's basically having community coalitions that work on trying to really deal with the power abuses that occur. And it's really looking at some of the structural issues that need to be faced. We need to organize, we need to be more effective, we need to basically be able to change the status quo, because the status quo is not working for patients with ME. And it's only by us collectively being involved in action is really the situation going to change. As it has, I might add, for many other illness groups, particularly the people with HIV/AIDS, who really have demonstrated that it is possible to bring about a sea change for treating and appreciating people who have that illness. We need social support for patients that involves the family, parents who basically protect their kids, guardians, spouses, parents who basically are able to stand up for the rights of individuals who are sick, and also people in educational settings, as well as social service settings, medical settings, and also within work settings, to basically provide for the special needs of patients. And we all have to recognize that first thing, this is a legitimate illness, and we have to be willing to accept some of the limitations that patients have. And we have to also validate their experience and work with them in terms of what they need. Individualized approaches are critical. So it's really the entire social network has to be mobilized, and that might involve the person's brother or sister, the person's father or mother, the person's grandparents, the people who work at their church, the people who are the medical associates. Everybody has to come together in a team that basically makes their life kind of more livable and actually has the respect and services that they need to make a quality of life. To bring about change is going to involve not just the patients who have ME, because many of them are sick, but it's also going to be involved the people who are well, the people who care, the people who are spouses. It's going to involve a social change movement of people saying, we're not going to take it anymore. We're going to make a change. And it's going to be thousands and thousands of people working together to say, this cannot exist the way things are. And that's going to be the start of the social change movement. That's not going to be in one country. It's going to be in multiple countries.
Heeft u een vraag naar aanleiding van deze video? Reageer op YouTube of tweet naar @ME CVS Vereniging of mail naar wvp@me-cvsvereniging.nl. Uw vragen worden zoveel mogelijk behandeld in de chatsessies.
We did an initial study involving actually medical textbooks, and we found that medical textbooks, which are used to teach future physicians, ME and CFS were really rarely mentioned. And worse even, when they were mentioned, they actually didn't often have accurate information about them. So the basic teaching materials that are being used in our medical colleges are very negligent and often inaccurate. That has to be corrected. We also have recently done a survey of kind of what does occur in medical colleges in the United States. And what we found was, again, these topics are underrepresented, and that has to change. There has to be more focus on teaching and actually application and research in medical schools. And until that changes, we're not going to have the people coming through the medical college who are adequate in basically providing the coverage that patients need. So this has to be one of the high priority issues that we work on. The research that we're currently doing, we think is constantly learning from the past. And yes, we're trying to integrate the type work, for example, with computers and people who kind of understand artificial intelligence, so that we can use not just a consensus way of making kind of a case definition, for example, but we can use basically the best sciences in things like data mining and artificial intelligence to come up with case definitions that might be more kind of specific and accurate and sensitive. So that's some of the work that we're currently doing. And we're also, again, trying to kind of look at sort of different ways of using multivariate and more complex modeling to have empiric ways of making decisions and understanding how systems operate, as opposed to trying to have just a consensus way of making case definitions or scientific pronouncements. We think that our research has made a difference. In the 1990s, ME was really considered a relatively rare disorder affecting kind of the yuppie flu. And at the time that our data have come out in the late 1990s and early 2000s, the prevalence estimates that are used by the federal government now indicate that they think closer to what our estimates are, 1 million people have this illness. So yes, we've been able to battle the misperception myth that this is a rare yuppie flu illness, and we now think it's basically a very significant illness that is not a yuppie flu that affects many more people than were previously thought to have this illness. In addition, our research has challenged the term CFS, and we have kind of championed trying to get alternative terms. And there's a number of organizations that are now using both ME-CFS and ME, and I think our research has helped contribute to that shift. Finally, I think our research on the case definition of comparing and contrasting different case definitions and using empirical methods rather than consensus methods to think about what are the core features and how to measure those core features, we think will continue to make important contributions to the debate that's currently going on the case definitions. So DePaul University doesn't have a medical school. There's been some talk about maybe some type of alliance with Rosalind Franklin, but it's in the very early stages. We have made some efforts to begin collaborating with people at Rosalind Franklin, but again, that's kind of early efforts at this point. We do think that multidisciplinary efforts are important. So we have an epigeneticist at Loyola that we're working with. We have an immunologist within the nursing department at DePaul that we work with we have a computer science expert in the computer science department that we work with, and we have people in different universities that we collaborate. So yes, I think it's critical for us to think about multidisciplinary research beyond the particular laboratories of our particular settings, and that's going to be the future of research, whether we have a particular medical school or not. We have several lines of research that we're focusing on. One is using our DePaul symptom questionnaire to gather large databases And we think with these large databases of patients versus controls, we'll be able to better understand which symptoms differentiate these groups. We're using very sophisticated, even artificial intelligence techniques that are empirically based rather than consensus-based in trying to help us inform the decisions regarding the case definition. In addition, we're not just interested in self-report issues with our questionnaire. We're also kind of looking at data that involves more physiological, biological measures. For example, we are now looking at college students and trying to find over time which one develop mono and which ones don't, and which ones recover and which ones don't. And we'll have blood samples on all those particular college students that will be able to kind of look at what were they like when they were healthy and what's going to happen after they get sick. And that type of longitudinal prospective research is critically important. I might add that we also have an epidemiology study going on with pediatric ME, and that's going to be an important kind of lesson for us to kind of also look at the biological as well as the other domains that help us understand what are the risk factors and how many individuals who have, within our youth, have this illness. And that's something that we'll be working on as well into the future. I think the most important research that will occur in the future is going to involve multidisciplinary efforts that are going to bring people in from different disciplines, including computer scientists who have mathematical gifts to help us understand decision trees so that we can figure out what symptoms might be best predictors of illness. We might be able to bring also people in from the best of the sciences, from virologists, from epidemiologists, from people who kind of understand the autonomic nervous system. So really what we are looking for is how do we have people from genetic backgrounds to environmental backgrounds, from public health backgrounds, all to participate in these types of rich multidisciplinary efforts to understand, we think, the greatest challenge to medicine today. Because medicine knows how to fix a broken bone. Medicine knows how to deal with people who have the flu. Medicine knows how to deal with many types of ailments. What's really a puzzle for individuals are these complex illnesses. And as we get insights into the mechanisms that are involved in complex illnesses like ME, we are going to have a new birth of understanding of what it is that individuals have to face and how we can better understand the human condition. And that type of research really needs to have the type adequate funding. And we will one day be able to reinterpret kind of different types of illnesses based on what we learned from people with ME. At the present time, there are many economic challenges to countries, and I think that these are difficult times for both basic researchers as well as patients. But I have faith and I have hope that basically, we will, over time, recognize that the greatest medical insights to occur will be involving the patients with the most complex system issues, such as ME. And as we get more scientists and researchers to understand this basic fact, my belief is that we will begin to bring together the best scientists in the world to study what I think is one of the most neglected but most important medical illness facing our world.
Heeft u een vraag naar aanleiding van deze video? Reageer op YouTube of tweet naar @ME CVS-vereniging of mail naar wvp@me-cvsvereniging.nl. Uw vragen worden zoveel mogelijk behandeld in de chatsessies.